We'll be talking about bone marrow failure diseases, including MDS, aplastic anemia, and paroxysmal nocturnal hemoglobinuria. So again, we'll review bone marrow failure and disease and discussing Myelodysplastic syndrome, the pathophysiology, clinical presentation, diagnosis, and treatment. Same with aplastic anemia, the clinical presentation, diagnosis, and treatment, and PNH, the pathophysiology, clinical presentation, diagnosis, and treatment, and review nursing considerations for bone marrow failure diseases. So bone marrow failure is an ineffective production of blood cells that cause pancytopenia, or a lowering of our blood counts, and the inability to produce healthy blood cells. Again, pancytopenia is the reduction in our blood counts of our red cells, white cells, and platelets. Bone marrow failure diseases can be congenital or inherited, or can be acquired over time. These disorders result in low blood counts or cytopenia due to decreased production in our bone marrow. Congenital bone marrow failure diseases include Fanconi anemia, Diamond-Blackfan anemia, and dyskeratosis congenita. However, today we'll be talking about acquired bone marrow failure diseases, including acquired aplastic anemia, MDS, and PNH. So myelodysplastic syndrome, or MDS, is a stem cell disorder that causes ineffective production of our blood cells, leading to cytopenia and an increased risk of developing acute leukemia. These are characterized by an increasing bone marrow failure in association with changes in our blood cells, meaning that they look abnormal in one or more of our cell lineages, in our red cells, our white cells, or our platelets. Bone marrow cells do not develop into mature blood cells and therefore stay inside our bone marrow in an immature state, and therefore lead to our bone marrow being hypercellular. However, in our peripheral blood, in our circulation, we have lowering of these blood counts because of these ineffective or immature bone marrow cells that stay in our bone marrow. So there's an abnormal regulation of proliferation, maturation, and survival of hematopoietic stem cells due to a number of genetic changes or mutations. These changes in the expression of genes can contribute to the development or progression of MDS, such as hypermethylation, and this results in the suppression of gene transcription. As the disease progresses, stem cells are further impaired with increased survival of myeloblasts. MDS usually develops in older adults greater than 60 years old with a median age of 72 to 76 years. It is more common in males than females, and it is a relatively common disease where there are 4 to 7 estimated new cases per 100,000 each year. The risk factor of developing MDS includes an older age, being male, being exposed to environmental factors such as benzene, smoking, or previous chemotherapy or radiation treatment. MDS can be caused by 2 different methods, either de novo or treatment-related MDS from previous chemotherapy or radiation treatment. So de novo MDS can be caused by idiopathic, which is just an unknown cause, being exposed to different environmental factors such as benzene, solvents, agricultural chemicals, smoking, autoimmune disorders, certain viral illnesses, inherited genetic abnormalities like trisomy 21 or Fanconi anemia, or other benign hematologic diseases. Treatment-related MDS refers to the development of MDS after chemotherapy or radiation therapy for a number of malignant diseases, including Hodgkin's and non-Hodgkin's lymphoma, multiple myeloma, breast, testicular, and ovarian cancers, or non-malignant diseases. Patients with MDS typically present with blood cytopenias, including anemia, thrombocytopenia, or neutropenia. Patients can range from being asymptomatic with an incidental finding in their CBC of having MDS to then having symptoms or complications related to the previously unrecognized cytopenia. The majority of patients present with red cell lineage dysplasia or anemia. Anemia occurs in approximately 90% of patients with MDS and is a major cause of morbidity. It is defined as a hemoglobin of less than 130 in males and 120 in females. Anemia can occur as a result of ineffective red blood cell activity in low-risk patients, whereas bone marrow failure can occur in higher-risk patients. Signs and symptoms include fevers or infection from neutropenia or a low white blood cell count, petechiae, ecchymosis, bruising or bleeding from thrombocytopenia or a lowering of platelet counts, and fatigue, shortness of breath, palpitations, weakness, exercise intolerance, dizziness, pale complexion, or cognitive impairment as a result of anemia or low hemoglobin. The diagnosis of MDS is dependent on two factors. One is the lowering of our blood counts or our cytopenias, and the second one is the evidence of dysplasia or cells looking abnormal in their peripheral blood smear or their bone marrow. In order to determine a diagnosis, we must look at a patient's history, so assessing for signs and symptoms of cytopenias, assessing for past medical histories and comorbidities that can also further impact their bone marrow or have effects on cytopenias, blood transfusion history, having a history of prior chemotherapy or radiation treatment, as we know that treatment-related MDS can occur, a family history, medications that can also contribute to cytopenias, or exposure to chemicals such as benzene or solvents that can also cause MDS. You must also do a physical exam to investigate for signs and symptoms of cytopenias, including looking at a whole head-to-toe assessment, looking at our skin for signs of petechiae or bruising, which are evidence of bleeding, looking at our mucous membranes, assessing for signs of bleeding such as nosebleeds, gum bleeding, hemoptysis, hematuria, or melena stool, assessing for signs and symptoms of anemia such as fatigue, assessing for vital signs, assessing for the presence of fevers and infections as a result of neutropenias, as well as the presence of splenomegaly. In order to diagnose MDS, we must do a number of diagnostic investigations. The first one would be blood work, so assessing our CBC with the blood smear, looking at our reticulocyte count, iron, TIBC, ferritin, LDH level, and EPO level. It is important to also do an initial rule-up to rule out other causes of cytopenia, so including a history of medications and toxic ingestions, vitamin B12, folate, urea, creatinine, TSH, HBV, HCV, HIV, PNH testing, as well as chromosome fragility testing. We must next do a peripheral blood smear to assess for dysplasia or abnormal looking cells in our red and white blood cells and platelets. Patients must also undergo a bone marrow biopsy and aspirate to evaluate the morphology of the hematopoietic precursors and blasts, as well as cytogenetics, or identifying abnormal chromosomes, which will be helpful for prognosis. The biopsy will show cellularity, so it will show that our bone marrow is hypercellular with these increasing number of immature stem cells in our bone marrow. Sometimes our bone marrow can be hypocellular as well. We must also do a flow cytometry to suggest clonality in the presence of MDS, and this is especially helpful when our dysplasia is minimal and we have normal cytogenetics or we have normal chromosomes. MDS is classified based on our blood counts, the morphologic appearance, the number of blasts in our blood or our bone marrow, as well as a genetic analysis. For prognosis, we assess the International Prognostic Scoring System, and this tool is very helpful at the time of diagnosis to estimate life expectancy for newly diagnosed patients with MDS. It identifies various parameters such as the cytogenetic risk group, so the number of chromosome abnormalities that we would have, bone marrow blast proportion, hemoglobin level, ANC absolute neutrophil count, and platelet count. We can then determine what risk group the patients would be in, which would then help us in determining their median survival and ultimately their prognosis. Factors that can predict outcome or prognosis can include the WHO classification of MDS, how many chromosome abnormalities that we would have, so if there's a complex karyotype, which would indicate more than 3, other chromosome abnormalities, the proportion of blasts in our bone marrow, as well as cytopenias, so lowering of our hemoglobin, platelet count, and white blood cell count. Even low-risk MDS patients have significant morbidity and mortality, including various transfusion requirements and associated complications. Worsening of pancytopenia, or acquiring chromosomal abnormalities, or an increase in the number of blast cells in our bone marrow indicate poor prognosis. And therapy-related MDS is an extremely poor outlook. The treatment is dependent on the patient's age, their performance status or their ECOG score, their prognostic score, what classification of MDS they have, and other various comorbidities. This helps us to determine what treatment goals with the patient and family they can have, including how to achieve hematologic improvement, reducing the number of transfusions that patients will have, delaying the transformation of MDS into acute myeloid leukemia, improving survival, and maintaining a patient's quality of life. So looking at low-risk MDS treatment options for a low-risk or intermediate risk 1, the goal of treatment is to minimize the cytopenias, help to maintain their quality of life, as well as to prevent morbidity and mortality from red blood cell transfusions and iron overload. For patients that are asymptomatic, we would be doing watchful waiting and monitoring every 3 to 6 months, assessing for their clinical history, signs and symptoms of infection or bleeding or anemia, doing a CBC, blood smear, and other blood work such as biochemistry, ferritin, and transferrin saturations. And if there are any changes in therapy that are required, then we would perform a bone marrow biopsy. For symptomatic treatment options, these would include medications for anemia such as ESA, lenalidomide. For neutropenia, it would include antibiotics or GCSF to boost their neutrophil count, and thrombocytopenia, and this would include antifibrinolytics. It could also include immunosuppressive therapy such as ATG and cyclosporin. Patients also would require supportive care such as transfusion supports, iron chelation. Doing an allo stem cell transplant assessment would help in that delayed allo stem cell transplant can offer maximal life expectancy as long as the transplant can occur before transformation to leukemia. Ultimately, the eligibility for allo stem cell transplants would be decided by the transplant center. Due to patients being older age or other additional comorbidities that patients may have, often stem cell transplant is not an option. The disease can progress to higher risk MDS, and there are potential indicators to indicate that this would be progressing, including a worsening of our blood counts, so further reduction in our hemoglobin levels, in our platelet levels, or in our neutrophil levels, a new cytopenia that could occur, the appearance of blast cells in our bone marrow, a rising LDH level, as well as systemic symptoms, including fever and weight loss. We would have to do a specific evaluation of higher risk MDS, which would include a bone marrow aspiration and biopsy to further assess those abnormal chromosome abnormalities and cytogenetics. The treatment options for high risk MDS, again, include the goal of treatment to change the natural history of MDS and defer transformation to acute myeloid leukemia, as well as improve survival for patients with MDS. The treatment options include hypomethylating agents, or azacitidine or decitabine, which is usually our standard of care. However, these are not a cure for MDS. AML-type chemotherapy can be tried in high-risk MDS patients, usually only if patients are going to be having a stem cell transplant. However, relapse is likely and can occur frequently. Again, depending on the patient's comorbidities and age, an allogeneic stem cell transplant may be an option. All patients require supportive care, including transfusions and iron chelation, as well as palliative care, and there are options for clinical trials as well. All patients should receive supportive care as it is an adjunct to chosen therapy. Patients with cytopenias and associated symptoms can receive supportive care, including transfusions of red cells or platelets, which must be CMV negative. In terms of nursing management, we must be identifying the symptoms of anemia, monitoring the CBC, monitoring for fluid overload, and advocating for diuretics. Also assessing the response to platelet transfusions in terms of assessing for platelet refractoriness and hemoglobin as well. Also monitoring for signs and symptoms of side effects of transfusions as well as reactions, as well as providing for iron overload. So iron overload management is determined by iron chelation therapy. So there are three options currently. So there is deferoxamine subcutaneous, which is a daily dose of 1,000 to 2,000 milligrams, which is administered over 8 to 24 hours using a small portable pump, which is capable of providing continuous mini infusion. The side effects of this kind of iron chelation therapy include an allergic reaction, as well as ocular and ototoxicity and cardiac dysfunction. Therefore, patients before treatment require a hearing and visual exam in order to assess baseline for ocular and ototoxicity. There's also deferoxyrox, which is an initial dose of 20 milligrams per kilogram, and this is orally, that it's taken on an empty stomach 30 minutes prior to meals. Again, these side effects include a lot of GI upset, GI hemorrhage, hepatic and renal failure, cytopenias, diarrhea, nausea, vomiting, and abdominal pain. There's also deferoprone, and the side effects of this include agranulocytosis. Therefore, it's important to measure the patient's neutrophil counts, and treatment must be interrupted if the neutrophil count is less than 1.5. The impact of MDS on patients and families is that the quality of life is very complex and can be individually defined for patients living with MDS. It includes looking at patient supportive care needs, including physical, social, emotional, practical, and spiritual needs, as well as looking at aging, comorbidities, and fatigue, and having an uncertain illness trajectory can affect the quality of life of patients. Therefore, oncology nurses are in an appropriate position to monitor the impact of the illness and treatment on patients and their quality of life through systemic assessment and providing appropriate interventions, referrals, and ongoing support. Moving to aplastic anemia, this is a stem cell disorder that occurs because the body's immune system attacks its own cells by mistake. Therefore, it's an autoimmune disease. Again, this disease is causing pancytopenia or lowering of our blood counts as a result of hypoplasia of our bone marrow. It can be inherited or acquired, however, the majority of cases are acquired. Again, it is the reduction in the number of the hematopoietic stem cells, and it's an immune reaction or error in the remaining stem cells, which cause them to not divide or then differentiate appropriately to populate the bone marrow. As we can see in the photo, our bone marrow is quite hypocellular, meaning that there are less cells, and it's mostly made up of fat cells. Again, aplastic anemia affects primarily children, and where the majority is inherited, or young adults, as well as there's a peak in older adults greater than 60. It is more common in people of Asian descent, and their incidence is 2 to 12 new cases per million each year. Again, it can be inherited or acquired. In most cases are idiopathic, meaning that there is no known cause. Other etiologies include exposure to different chemicals or drugs, such as NSAIDs, phenytoin, radiation, viruses, or other immune diseases. Clinical features: patients present with signs and symptoms of pancytopenia, including most frequent symptoms of bruising, bleeding gums, nosebleeds, and symptoms of anemia, such as pallor, headache, palpitation, shortness of breath, or dyspnea, fatigue, and foot swelling. Again, infections are very common and are frequently life-threatening. The diagnosis of aplastic anemia is a diagnosis of exclusion, in that there is no single test that reliably diagnoses idiopathic acquired aplastic anemia. Again, we must be assessing patients' blood work, so looking at CBC with differential, vitamin B12, folic acid, LFTs, LDH, chem panel, coagulations, and assessing for pancytopenia early on. Patients must also have a bone marrow biopsy and aspirate. And after doing a bone marrow biopsy, we can see that the bone marrow is profoundly hypocellular, that the space is mostly made up of fat cells. Again, we must also do a flow cytometry to detect coexisting disorders that can occur, as well as cytogenetics to rule out MDS and other congenital disorders. The classification of aplastic anemia varies from severe, very severe, and non-severe. Severe aplastic anemia is the presence of 2 to 3 parameters, including a neutrophil count of less than 0.5, platelets of less than 20, or reticulocytes less than 1%. Very severe aplastic anemia is when our neutrophil count is less than 0.2. Non-severe aplastic anemia is not fulfilling any of the severity criteria, and the chronic needs are greater than 3 months. The treatment of aplastic anemia depends on the severity and if it's not severe. Very severe and severe aplastic anemia stages require treatment, as this causes a very high mortality rate. So patients can undergo a stem cell transplant depending on their age and if they're in good health. For greater than 50 years of age, we usually initiate immunosuppressive therapy, including ATG, which is anti-thymocyte-globulin, and this is horse ATG that's administered IV over 4 days. This requires pre-medication with Tylenol and Benadryl to decrease reactions and serum sickness reaction. It also requires daily steroids to reduce the risk of serum sickness. There is a risk of anaphylaxis, and so therefore during infusion, nurses keep an anaphylaxis kit at the bedside in order to provide medications quickly. Patients are also on cyclosporin, and cyclosporin is an oral medication, and the side effects include hypertension, renal insufficiency, lowering of our magnesium, and gum hyperplasia. So therefore it requires constant blood pressure monitoring of our creatinine, and regular dental care as well. For non-severe patients, this is an individualized approach. It's usually based on symptoms, disease severity, and if there are any changes in cytopenias. However, it's usually close monitoring without immunosuppressive therapy if there are minimal symptoms or transfusion requirements. Serum sickness, like I mentioned, occurs 1 to 2 weeks after initiating the treatment of ATG. It's a flu-like illness that accompanies with rash and arthralgia, and the treatment of serum sickness is steroids. Patients with aplastic anemia also require a lot of supportive care, including transfusions of red cells and platelets, and they must have irradiated blood products as well. Patients also require treatment of infections, including empiric therapy with broad-spectrum antibiotics if they have an infection. They can also use growth factors as prophylaxis to prevent further infections if they keep having repeated infections over and over again. Also, as nurses, we must be providing patient education on infection prevention and monitoring, so monitoring for fever and signs and symptoms of infections. PNH is paroxysmal nocturnal hemoglobinuria, and it's acquired hemolytic anemia. It is sudden irregular hemoglobin in our urine at night, and it causes hemolysis because blood cells are missing proteins that protect them from a part of the body's immune system called the complement system, and when they break apart, the hemoglobin that's inside then is released, and this causes the symptoms of PNH. It's characterized by hemolysis, venous thrombosis, and pancytopenia. The triad makes PNH a unique manifestation. However, when there are not all three present, diagnosis is often delayed. The pathophysiology of PNH is that the affected cells of the PNH clone have a deficiency of an entire class of cell surface proteins known as GPIAP. These proteins function as enzymes, receptors, complement regulators, and adhesion molecules. The GPIAP defect in PNH results from a mutation in a gene, which is PIGA, and this is the product of which is involved in an early step in the synthesis of the GPI anchor. Two GPIAP that protect red blood cells from the complement activity, CD55 and CD59, are lacking on the surface of the PNH red blood cells. Therefore, these cells are highly sensitive to complement-mediated destruction, and the condition allows PNH stem cells to expand in numbers so that more of the mature red blood cells are found in our blood are abnormal. PNH is the same frequency in men and women, and it is a very rare disease. The prevalence is estimated at 5 in 1 million. It can be present in small children or older adults, and most of the patients are young adults. The clinical presentation of PNH includes anemia, and this can result from a combo of the hemolysis and bone marrow failure that occurs. There's also thrombosis or blood clots, and the common sites include intra-abdominal, so we can get blood clots in our hepatic, portal, mesenteric, or spleen, as well as cerebral veins with hepatic vein thrombosis. We can also have GI symptoms such as abdominal pain, esophageal spasm, and dysphagia or difficulty swallowing. Other manifestations include gross hemoglobinuria or hemoglobin in our urine, as well as kidney damage. It is diagnosed with blood work, and so we're looking at our CBC with differential, liver profile, bilirubin, LDH, and reticulocyte count, as well as a urinalysis to assess for the hemoglobin level in our urine, as well as a flow cytometry to identify this GPI deficient peripheral blood cells. The treatment of PNH is supportive care, so patients receive transfusions. They also receive folic acid or iron supplementation, as well as the treatment of different complications like our thrombosis, so they receive anticoagulation. Also, there is a new biotherapy, eculizumab, and this is a humanized monoclonal antibody against C5 that inhibits the complement activation, and it has demonstrated a dramatic effect on intravascular hemolysis and transfusion requirements. This has helped to improve patients' quality of life. It can also reduce the risk of life-threatening thrombotic events. Again, the medication must be continued for life, and it is very expensive. Stem cell transplant for young patients with severe PNH is also an option. And there's primary prophylaxis for thrombosis, so anticoagulation prophylactically. Nursing considerations for bone marrow failure diseases include a comprehensive assessment of patient and management of different side effects. It's also monitoring for signs and symptoms of those low blood counts, including fatigue, bleeding, and infection, and then providing appropriate interventions. It's also addressing the patient's supportive care needs, so looking at their physical, emotional, psychological, social needs as well. It is providing a lot of patient education on understanding the disease, the various manifestations and clinical presentations, treatment options, and the adverse effects of these treatments. It's also to connect the patient to the hospital and different community resources, like AAMAC. So the Aplastic Anemia and Myelodysplastic Association of Canada is a not-for-profit group that seeks to provide support, education, and research for Canadian patients, families, supporters, and healthcare providers that deal with aplastic anemia, MDS, and PNH. Currently, there are support groups in Vancouver, Edmonton, Toronto, Kitchener, York Region, Durham Region, Ottawa, Montreal, and Halifax. And patients and families can be directed to the AAMAC website or via telephone or email for more information. They also provide educational material, quarterly newsletter, local support group meetings, and grants for medical research and education. Thank you.